يشرفنا اليوم الدكتور عبدالرزاق شليبك consultant hematologist with special interest in hemostasis and thrombosis. هو استشاري ورئيس أقسام أمراض الدم في الإمبريال كوليدج اوف هيلث كير لندن نورث ويست يونيفرسيتي هوسبيتال. هذه سلسلة محاضرات عن الهيموستاسيس and thrombosis. هذه المحاضرة الثانية بعنوان الكانسر and thrombosis. شكرا جزيلا دكتور، تفضل.
شكرا عائشة، وشكرا للدكتور المهدي وكل الإخوة الموجودين والأخوات. نتشرفوا معاكم إن شاء الله كالمعتاد. اليوم هنتكلموا على very important topic which is cancer and thrombosis. This is a very common problem. Cancer, we see more and more people with these conditions, and thrombosis is one of the commonest complications. We try to comment on where we are currently and what is the future holds for this particular area. So okay, can't move the slides now. The lecture will be divided into several components. We talk about how common this condition is, what are the possible mechanisms, and then we will talk about prevention of thrombosis. There's both venous and arterial thrombosis. And then we will talk about what are the therapeutic strategies available at the moment for these patients. So we start with epidemiology. Cancer-associated thrombosis is usually abbreviated as CAT, C-A-T. CAT is 4 to 7 times more likely to develop in cancer patients. Fatal PE is 3 times commoner in cancer patients. So this is a relatively common cause of death in patients with cancer. It's number 2 cause of death in actually cancer patients after the cancer itself. And it's common both in people are in the hospital, so this is for inpatient or hospitalized patients. It's also common in people attending for ambulatory treatment. So those attending for chemotherapy, those attending for hormonal treatment, or nowadays monoclonal antibody therapy. The numbers are there in the slide for your information. And clearly, the association between cancer and thrombosis is two-way system. So cancer can cause thrombosis, and thrombosis is a common presentation in people of cancer even before the cancer appears. So in managing people who present with what we called unprovoked venous thromboembolism, one of the important clinical management points is to make sure that these patients do not have cancer. So we look for cancer in these patients if we cannot identify any cause of venous thromboembolism. And if you look at the statistics, for those who present with the first event of venous thromboembolism, about up to 50% of these patients are what we call idiopathic. Idiopathic means they don't have trauma, road traffic accident, recent orthopedic surgery, or other risk factors. And in those patients, between 15 to 25% may be associated with cancer. And if you follow up after surgery, you can see about 20% of those patients may present with thrombosis related to that. In those patients who have recurrent venous thromboembolism, there is a higher rate of patients with cancer because cancer is a continuing risk factor for the venous thromboembolism in particular to have recurrence in those type of patients. And recurrent pulmonary embolism is more likely to happen after deviant thrombosis in those patients, in particular if they have cancer. So risk of embolization after DVT seems to be more common in cancer patients as compared to non-cancer patients. And at the bottom side, it shows how cancer contributes to those who present with fatal venous thromboembolism. 30-day incidence is 6% after deviant thrombosis and 12% after pulmonary embolism. So this is specific in these group population and both age, cancer, and the presence of cardiovascular disease are clear precipitants or clear risk factors for fatal venous thromboembolism. This is a very interesting study which was performed about 10-15 years ago now, looking at incidence of cancer in medical and surgical patients. This is a very big study which has actually rolled out in about 32 countries and involved over 350 hospitals across the world. And what this study have shown that overall there is 50% risk of developing PE, and these are actually in a big number of patients. As you can see, they've looked about 70,000 patients, slightly more medical than surgical patients, but they looked at the criteria for developing guidelines for thromboprophylaxis, and they've specifically looked for what percentage of patients who are admitted to the hospital will be classified as increased risk based on the American College for Chest Physicians criteria. And they only found only half of the patient have received thromboprophylaxis, which is preventative measures for venous thromboembolism based on the criteria, which is risk stratification based on the American College for Chest Physicians. And they identified that nearly two-thirds of the patients who undergoing surgery were at risk of venous thromboembolism, but only 60% actually received the prophylaxis. So two-thirds of the patients at risk, and only 60% of those two-thirds actually received the appropriate preventative measures. For medical patients, they've identified about 4 in 10 patients were at risk of venous thromboembolism, and only 40% actually were given prophylaxis. So it's quite obvious from this global study, which has looked at practices across North America, Europe, Africa, and Asia. So this is actually a very representative study looking at the problem globally. It has identified a very important gap in our risk stratification, and also identified a gap in actually our duty of care as healthcare professionals in offering venous thromboembolism prevention. And this is a very fatal condition which we can prevent by giving the appropriate measures. You can stop people dying. Now, we know that the risk of thrombosis in cancer patient very much depends on the type and time of diagnosis. If you look at the bottom there, it gives you the different diseases or the different cancers, hematological, bronchogenic carcinoma, gastrointestinal, breast, and patient with localized disease, as well as those with metastatic disease. The second half of the slide shows time of diagnosis. If you look at the incidence, this is a mega study, it's a population-based case control study, looked at over 3,000 patients with nearly 2,000 matched controls. It has shown that there's a significant increased risk of thrombosis in certain cancers. These cancers include hematological cancers, in particular lymphoma and myeloma, but also identified other groups of cancers which are associated with increased risk. These are in particular adenocarcinoma type cancers, and we will talk about in a minute. However, those with metastatic disease or metastatic cancer, the risk is much higher. The biggest risk is in the first 3 months from diagnosis. As you can see, 54% of the patients who presented in the first 3 months from diagnosis as compared to the subsequent. As time goes on from diagnosis, the risk becomes less and less. So the first 3 months is the biggest or the highest risk, and then the subsequent 6 to 12 months is the next sort of period of increased risk. Now, cancer patients treated with different modalities. Some patients require surgery for their cancer, breast cancer, for example, colorectal patient, liver cancer, and so on. They may undergo surgery for their cancer. They will also have chemotherapy subsequently, and some of them may end by needing hormonal treatment. Now, this is a study which looked at breast cancer patients, and it looked at over 13,000 patients between 1997 and 2006, and identified among those group the incidence of venous thrombosis is about just under 5% in these patients, but identified blocks of risk based on the different treatment they undergo. For example, if you look at the risk of surgery, you can see at the bottom there, those who did not have surgery, the risk is quite small. And those who had surgery, depending on the time of surgery, the risk is increased. In particular, if they had surgery acutely, and the risk is higher in the first period after discharge. The biggest risk is between 1 to 3 months after discharge. What about chemotherapy? Is very similar. The greatest risk of venous thrombosis is in the early stages of giving chemotherapy and in the first month after initiation of chemotherapy. Now, tamoxifen and other aromatase inhibitors, which are the hormonal treatment for cancer patients, there is a more or less a constant risk associated with the hormonal therapy for these patients. Now, this is another study which have looked at, it's called Million Women Study. This is a study looked at about 1 million women who underwent different procedures, including orthopedic surgery, gynecological surgery, surgery for other procedure, abdominal and pelvic. And this is actually extremely informative. I summarized the number here in terms of the overall risk is 1 in 140, compared to 1 in 6,000 if they didn't go surgery, if they didn't undergo surgery. So you can see the risk with surgery is 1 in 140 compared in 1 in 6,000. And you look at the second component here, you can see the commonest risk factors is associated with orthopedic surgery, and subsequently the biggest risk is related to cancer, and much less a risk in ambulatory patients who undergo daycare procedures. And as you can see, if you look at the curve, the maximum risk is usually in the first 4 weeks after the procedure has been undertaken, but the risk doesn't come to the baseline up until about 12 weeks after whatever procedure they underwent. And then if you look at the different periods after the surgery, there are 3 different periods here. First 6 weeks after surgery, 7 to 12 weeks, and then after 4 months. And if you look at the numbers I highlighted there, these are default increase in relation to cancer. So these are the cancer increased risk of venous thromboembolism in these population or these periods. What about ovarian cancer? Very similar sort of data. Both surgery as well as chemotherapy, neoadjuvant chemotherapy has been associated with increased risk, more with pulmonary embolism as compared to DVT in certain groups of patients. But as you can see, it's equal incidence at time of presentation and during chemotherapy. So these are really the earlier period without intervention, because some of them have to undergo surgery, and then at the initiation of chemotherapy, these are the two highest periods of risk. So what about if you look at the incidence of thrombosis before you commence therapy? And depending on the different cancers, this is a study in gynecological cancers in general, looking at cervical, endometrial, and ovarian cancer. You can see adenocarcinoma, in particular ovarian, is associated with the highest pre-treatment risk of thrombosis. And again, this highlights the importance of risk stratification and introducing venous thromboembolic strategy to prevent the occurrence of venous thromboembolism, because you will be preventing deaths. I've mentioned earlier on in my introductory slide that cancer-associated thrombosis is bidirectional. And this is, cancer diagnosed patient, they can present with venous thromboembolism early on or later on, depending on where is the cancer, what type of cancer it is. Could be surgery for the cancer which precipitated the thrombosis. In this respect, I'm talking about patients who present with thrombosis but have no symptoms of cancer. And it is now mandatory you do something called cancer exclusion in patients who present with what we call idiopathic thrombosis or unprovoked thrombosis, where you assess this patient. You have to ask yourself the question, do they have cancer? Is that why they have the DVT? This is a very good study done a few years ago, looking at screening for occult cancer in patients with unprovoked venous thromboembolism. Now, the screening can be very simple screening. You can just see the patient, examine them, talk to them, do basic blood tests, full blood count, urinase, liver function test, urine test, or you can actually go even further and do imaging like CT scan. Some of the studies have looked at PET scans, or you can do limited imaging into the abdomen and pelvis by just simplified normal ultrasound scan. The detection rate increases with more investigation you do, but sadly, it doesn't make a huge difference in terms of the outcome, because by the time patients present with the thrombosis in relation to cancer, even if the cancer is occult, this is itself is associated with, unfortunately, very poor prognosis, because most people who present with thrombosis and cancer, it seems to be a relatively late occurrence in their disease. There are several other studies looked at this. I've highlighted some of these studies in different links there. You can look at more studies done at around the same time. What is the recommendation for investigating patients who present with unprovoked venous thrombosis if you are looking for cancer? As I've mentioned already, NICE, or National Institute for Clinical Excellence in the United Kingdom, they've got a specific guidance for these patients, and it's been updated recently. And these are the investigation you need to do. You need to do a proper clinical history and physical examination, and then a chest X-ray, simple blood test I've mentioned earlier on, calcium, full blood count, liver function, and urine analysis. Now, practices differ, and some people do tumor markers, they do imaging. The imaging can be variable. However, there are groups of certain patients which should really raise your awareness and should raise your index of suspicion about the presence of cancer. These include people with bilateral deviant thrombosis. If the D-dimer levels are very high, normally more than 3,000, and if they presented with early recurrence of venous thromboembolism. It's quite unusual for people who present with venous thromboembolism. You initiate anticoagulation therapy. If somebody you think their thrombosis has extended or recurred within earlier stages of treatment, then that should really raises the alarm for likelihood of cancer. Now, for any intervention you undertake, you really need to be sure that you are targeting the right age group of patients. And most of the recommendation, for example, for women for mammography presenting with venous thromboembolism, usually over the age of 40, that's where you would suspect the cancer. For the younger age group, you have to look for other risk factors like using the combined oral contraceptive or experimenting with drugs and things like that. So that gives you an idea about the relation between cancer and thrombosis, both cancer patients presenting with a thrombosis or people presenting with thrombosis, no signs or symptoms of cancer, and they may have occult malignancy, and you look for it if your resources allow that. Now, the second part of this early discussion is, how does cancer cause a thrombosis? And this is a cellular level showing how does the tumor cells interact with different components of the coagulation cascade. The biggest important area is actually the interaction between cancer cell and tissue factor. Now, last month when I did my initial talk, I told you that the coagulation activation usually starts with tissue factor. So tissue factor generation is very important as initiation of the blood clot formation. And cancer cells interact with tissue factor quite optimally. And this will result in thrombin generation. Thrombin generation activates fibrin formation and blood clot formation. The other important element which cancer is extremely good in is something related to the generation of tumor microparticles. Tumor microparticles are very good stimulant for the thrombin generation, as well as extremely good in activating platelets. So patients with cancer have several areas where the coagulation cascade is activated. Tissue factor upgrade resulting in thrombin generation, platelet activation, tumor microparticles, platelet microparticles. Some of these tumors produce something called adhesion molecules. Adhesion molecules will result in actually adherence to the endothelial cells, and endothelial cells will result in the generation of more breach of the endothelium, and this will result in the beginning of a blood clot related to the cancer. So there are several mechanisms there eventually result in the patient with cancer having what we call a prothrombotic state. So this is very similar to individuals who may have thrombophilia, like protein C deficiency, antithrombin deficiency, antiphospholipid syndrome. Cancer make these patients have a prothrombotic tendency, and therefore increases their risk of thrombosis. Again, this is a little bit more detailed showing of the tumor cell in the middle there interacting with tissue factor, which result in generation of tissue factor 7A activation and resulting in activation of the classical coagulation pathways. Tumor markers also activate platelets directly or activate other coagulation activation pathways. For example, result in reduction of fibrinolysis. So the fibrinolysis activity is reduced. Tumor markers also increased upgrade the activation of monocytes. Monocytes also adhere with tissue factor and increase this as a vicious cycle, which is driving the coagulation activation and presenting a prothrombotic state. At the bottom of the slide where the endothelial cells are, you also have adhesion molecules generated, including TNF, IL-1, VEGF. All these will actually result in endothelial activation. Now, endothelium integrity is very important for keeping the coagulation activity inactivated. If the endothelial is damaged or breached, and cancer is extremely good in doing that, this will result in activation of the coagulation cascade. And then, in addition to the biological pathway, which I've mentioned to do with the cancer cells interacting with the coagulation, with the platelets, with the endothelium, and so on, you've got other risk factors. Cancer patient, in addition to the cancer, and in addition to the biological changes in their coagulation cascade, they will have other risk factors like anybody else. If they are obese, if they are of advancing age, if they are immobilized because they are unwell, if they are dehydrated, if they had central lines put in, if they had other thrombosis factors like treatment with chemotherapy, treatment with biological therapy now, all the different monoclonal antibodies, all these unfortunately predispose to thrombosis in these patients and result in increased risk of having venous and arterial thromboembolism. Now, the biggest improvement over the last 20 years is really coming up with a prevention strategy to stop a cancer patient having thrombosis. So it is the duty of all doctors and nursing and other healthcare professionals to ensure that patients are risk assessed, and based on their risk assessment, they should be given the appropriate prevention strategy. What are these strategies? So this is again just to re-emphasize that there are several reasons why the patient have or increased risk of thrombosis. Some of these are related to the diagnosis of cancer itself. Some of these are related to the treatment. Excuse me. Some of these are related to the treatment of the cancer, whether it is surgery, chemotherapy, hormonal, erythrocyte stimulating agents like erythropoietin we give for patient with cancer-associated anemia, patient required to be admitted in the hospital, people who have central catheters, but there are patient-associated factors. We've mentioned age, we've mentioned ethnic groups, we've mentioned history of venous thromboembolism in the past, or having co-inheritance of other prothrombotic conditions. So let's look at what are the strategies available for patients nowadays. This is the American Society for Hematology, which is an extremely good source of guidelines, extremely good in getting your information if you are looking for information. And they have published specific guidelines for prevention and treatment of patients with cancer with venous thromboembolism. And then they summarized their recommendation based on the evidence. The stronger the evidence for specific recommendation, they said this is a strong recommendation. If they have less evidence, they will say this recommendation is conditional. So for prevention, they said not using prophylaxis for ambulatory patients. So for patients attending for chemotherapy as a daycare procedure, they're coming to have their infusion and going home. There is no evidence to suggest that giving chemical thromboprophylaxis, this is low molecular weight heparin, warfarin, or direct oral anticoagulant, what we call DOACs or NOACs. There's no evidence to support that it will work in these patients. Now, for treatment or treatment of venous thrombosis, so somebody who's been diagnosed with VTE, until recently, low molecular weight heparin has been the preferred option for treatment of venous thromboembolism. We will talk about the recent studies and recent data looking at DOACs as a possible modality for that. What about conditional recommendation for preventative measures in hospitalized medical patients? So this is a cancer patient who has not undergone surgery. You can look at the risk assessment and make up your mind. For surgical patient, you offer them automatic prophylaxis with low-mercury heparin or fondaparinux, which is a synthetic pentasaccharide. It's very effective preventative measure. And for ambulatory patient with cancer receiving systemic therapy, but considered to be at high risk of venous thromboembolism, you can use either low-mercury heparin or a DUAC. This is the new oral anticoagulants. What about treatment options? For the treatment, now they are saying you can either use low-mercury heparin or DUAC. For short-term treatment, DUAC will be fairly appropriate because they simplified the management of venous thromboembolism massively. And for long-term treatment, you can use either. So these are the summary of the guidelines looking at how you manage these patients. Now, one of the commonest problems really is how long would you need to treat these patients for? Now, there isn't really black and white answers here. And you could actually summarize the duration of anticoagulation is you can treat them as long as they either have cancer or active management of cancer. Active management of cancer could include chemotherapy, radiotherapy. They may need frequent surgical interventions. As long as that's the case, they should really be anticoagulated. You can stop the anticoagulation after 6 months, or if they are in clinical remission. Clinical remission means that there's no active cancer detected any longer. So let's look at, again, at the evidence for what I was saying. So the American Society of Clinical Oncology and American College of Obstetrics and Gynecologists recommend thromboprophylaxis for cancer patients undergoing surgical intervention, starting before surgery for at least 7 to 10 days. And then they said to consider extended prophylaxis in high-risk patients. So what is extended prophylaxis? Extended prophylaxis is prolongation of the prophylaxis for prevention for up to a month after the surgical procedure. So this is not really a universal recommendation, but it's only in patients who are considered to be in high risk. And then the next component is extended prophylaxis in patients undergoing open cytoreduction for cancer to reduce the incidence for venous thromboembolism postoperatively. With regards to minimal invasive surgery, so for those who are undergoing laparoscopic interventions, the data is at the moment is not very clear and left to the discretion of the treating oncologist or surgical team. Now, when we say extended period, what do we mean? How long it's for? Now, this is a very important study which have looked at incidence of venous thromboembolism. Look at these days post-surgery at the bottom. They looked at offering prophylaxis for periods of time. And then they've identified that for a significant number of patients, they presented with thrombosis actually after discharge up to more than 30 days after discharge. And remember, most of us used to give thromboprophylaxis for 7 to 10 days. And after 10 days, we think everything is fine. This study was very clear. The Arostus surgical cancer patient study have shown that, whilst we give thromboprophylaxis for most of the inpatient we are in the hospital, in this study, 82% were given prophylaxis whilst inpatient. Only 31% received post-discharge thromboprophylaxis. And as you can see, this study showing the risk is still there quite long time after being discharged from the hospital. And the arrow there outlines the increased risk up to 6 weeks after surgery. Remember, I showed you a very good study earlier on. This is the Million Women study showing that, yes, the risk is maximum at 6 weeks after, but it actually extends to up to 3 months and 4 months after having surgical procedure. And you need to look at your patient specifically and identify if your patient falls into this category of those who need extensive surgery. Now, look at the mortality, 1.7%. This is after discharge. Half of those who died after discharge because of a fatal PE. So it's really very powerful message telling you that in certain groups of patients, you have to do the prophylaxis for much longer than when they were in the hospital. And you have to extend it for at least for 4 weeks afterwards in order to reduce the mortality related to late onset venous thromboembolism after surgery in cancer patients. Another study showing very similar data. This study also tells you the risk of bleeding, and it's quite obvious have a favorable outcome in terms of safety because the risk of bleeding is only slightly increased. So all these studies are low molecular weight heparin, showing that if you extend it, you will benefit from it without the significantly increasing risk of bleeding. Okay, so we've talked about surgical patients, we talked about inpatients, we talked about extended prophylaxis in certain groups of patients. Now, what about those attending for daycare procedures, daycare cancer therapy? We've mentioned already the American Society does not provide support for that, but let's look at the evidence in general. So this is a good study which have looked at several modalities. First one, this is a very old study actually, which has given patients a small dose of warfarin without monitoring their anticoagulation in breast cancer. And then there are several other studies looking at breast, non-small cell lung cancer, and primary CNS gliomas using different modalities. And as you can see, comparing a placebo with the anticoagulant therapy, and the bottom line, there was no difference between doing the placebo and doing active arm, which is related to giving low molecular weight heparin. And this is a summary slide which shows most of the recent studies looking at ambulatory patients undergoing chemotherapy for cancer. And I think the consensus is at the bottom in red. It shows these patients have low event rate for venous thromboembolism, and it trend towards increased bleeding with any form of anticoagulation. So the message really is, for those who are attending for our CHOP, for chemotherapy for multiple myeloma, without the use of thalidomide or thalidomide-like medications, the risk of giving prophylaxis outweighs the benefits. So the risk of bleeding increases in these patients, and therefore the benefit from giving the anticoagulation is not being established. Okay, now we come to which medications can we use? What will be the therapeutic options available for us, both for prophylaxis in cancer patients to prevent thromboembolism, as well as what will be the non-pharmacological options. So I've listed here low molecular weight heparin, fondaparox, unfractionated heparin as parenteral pharmacological antithrombotic. And more recently, we have now a group of drugs which we call as NUACs or DUACs. But also, it's very important to remember there is good evidence for using of things like intermittent pneumatic compression devices, elasticated stockings for patients in particular being admitted to the hospital and undergoing surgical procedures. Okay, so let's look at some of the recent studies. This study has looked at the use of rivaroxaban. This is using one of the new direct oral anticoagulants. This is in a high-risk ambulatory cancer patients receiving systemic therapy. Randomized controlled study was published a couple of years ago. Risk-adapted approach using a validated score, targeted prophylaxis for. So what they've done here, they didn't give rivaroxaban to every ambulatory patient. They have a validated clinical score to say, by using that score, they can risk stratify their patient to low, medium, or high risk. And they only given rivaroxaban to patients who are considered to be high risk. And they followed these patients up to 180 days, which is practically 6 months. And they've looked at risk of developing venous thromboembolism. And as you can see, significant p-value, 2.62% on those who had rivaroxaban as compared to 6.4% on those who had the placebo. And this is actually a good number. It's nearly over 400 in each arm, and it's very good indication of informing us that we don't need to give it to everyone, but we can select our patient who may benefit from it. So this is another way of looking at the study, and this is looking at what are the numbers needed to treat, and what are the numbers needed to harm in order to actually reach the benefit of having the medication. And as you can see, these numbers are fairly favorable in terms of you treat 100 patients to stop 1 patient dying from pulmonary embolism or deep vein thrombosis. And this is a very common measure of studies, for example, used many years ago in acute coronary syndrome. How many patients you need to give thrombolysis in order to stop 1 patient dying? Are you killing more patients because you're giving the medication, or is the numbers needed to treat much more significant than the numbers needed to harm? And the study has concluded that using rivaroxaban in a targeted manner reduced venous thromboembolism and VTE-related deaths during the treatment period with a significant lower risk of bleeding, but you have to have a Corona score risk of more than 2 in order to achieve that benefit. What about treatment for cancer-associated thrombosis? So the treatment is divided into several stages here. The first 6 months, after 6 months, and then what happens now, we've got more new evidence using newer agents in clinical practice. And, for the first 6 months, most people will give, until recently, they will give low molecular weight heparin. And that low molecular weight heparin was very much based on a study which I'll show you in a minute. It's called the CLOT study. So 6 months low molecular weight heparin, but you can carry on treating the patient as long as they still have cancer, demonstrable, or they're still undergoing active cancer therapy with chemotherapy, radiotherapy, or other alternatives. Obviously, hormonal treatment for breast cancer is not considered to be a criteria for continuing anticoagulation, although tamoxifen and aromatase inhibitors also increase risk, but they're not really considered as a definite indication for continuation of anticoagulation indefinitely. Now, this is the CLOT study I've mentioned earlier on. This is a fairly important study, looked at comparing vitamin K antagonist at the top, which is warfarin or Coumadin, depending on the country, compared with dalteparin. Dalteparin is a low molecular weight heparin. And they've studied 336 patients they managed to reduce the risk of venous thromboembolism by 52% in those who were given dalteparin as compared to those who had warfarin. And there was a significantly difference between the two modalities. And this is really the basis and the foundation which has made the recommendation of using low molecular weight heparin in patients with cancer. And until now, a lot of practitioners would consider this is the gold standard. Although the use of anticoagulation, in particular low molecular weight heparin, did not make difference in terms of prognosis and survival, because unfortunately, most of these patients' survival is dictated by their underlying cancer rather than by the diagnosis of venous thromboembolism. But they've managed to identify a difference between a group of patients who, if you dissect the patients in those with and without metastasis, so those who have a limited disease compared with those with metastatic disease, the low molecular weight heparin seems to outperform oral anticoagulation again. And as you probably, some of you may remember, a few years ago, some people thought even low molecular weight heparin may have anti-cancer properties, and they started experimenting with use of low molecular weight heparin even in the absence of cancer. I have to say, those studies were very exciting and was very interesting, but eventually they were discontinued because there was no evidence to suggest that use of low molecular weight heparin outside venous thromboembolism had any benefit in patients with cancer. This is another study. This is more recent. It's called the CATCH study, comparison of acute treatments in cancer hemostasis. This is using a different low molecular weight heparin called tinzaparin. A bigger study, it's 450 in each arm. Again, they've shown very similar outcome to the clot, although statistical significance was not achieved. But the two studies are slightly different in terms of a choice of patients and in terms of cancer as a percentage of the presenting group. I think with the CATCH study, there has been more extensive cancer in this group as compared with the clot study. And some of the critical data analysis may be related to the patient characteristics rather than to whether tinzaparin is inferior or better than dalteparin. So that sort of analysis is there. And the conclusion were very similar, that low molecular weight heparin has been as good as anything else. This is the design study. I've mentioned some of these points already between the clot and the CATCH. And for example, if you look at the stage of cancer between the different, in the middle of the slide there's more patients who presented with advanced cancer in some of the study as compared to the other. Okay, this is what we called a meta-analysis, combining all the different studies with low molecular weight heparin versus Coumadin or vitamin K antagonist warfarin if you are in the United Kingdom, Coumadin if you are in America, Synthrome or Acinocumarol if you are in some parts of Europe. And as you can see, there's an overall benefit from low molecular weight heparin as compared to vitamin K antagonist. And there's a 40% reduction in recurrence rate. And at the bottom of the slide, it showed no significant difference in the risk of bleeding. So all in all, it tells us that low molecular weight heparin would be the preferred option in these patients because of better reduction in recurrence of thrombosis and similar risk of bleeding. So there's no advantage in going for one or the other based on that. What happens after 6 months? We don't have any specific guidance. There's no evidence base for what you do, and people can do whatever they want to do. You can carry on with low molecular weight heparin if the patient prefers to go on injecting themselves, or you can switch over to warfarin, and more recently now you can actually use oral anticoagulants. Another study looking for tinzaparin in cancer patient after 6 months. So the initial study by tinzaparin looked for 6 months only. This is beyond 6 months, and there's no really sort of major message there, except it is doable. It does not increase risk of bleeding, and if the patient likes, they can carry on doing that as compared to taking warfarin or a DUAC. And it just shows you the risk of venous thromboembolism recurrence in those different groups. And again, the different studies looking at different low molecular weight heparins after 6 months. Sorry. So these are studies after 6 months, and it shows the efficacy in terms of preventing pulmonary emboli and deep vein thrombosis in these patients, and the associated untoward effects, and giving some of the types of cancers at the bottom. As you may have noticed, most of these cancers are adenocarcinoma associated malignancies, and some of them with metastasis. Okay, so finally we come to what will be the other options. You know, we are 2023 now. There's now quite few studies showing that direct oral acting anticoagulants like DUACs or NUACs have shown good efficacy, as good as low molecular weight heparin as the gold standard. These are the different DUACs, and this is where they work on the coagulation cascade. The commonly used one are the factor VIII inactivators or factor VIII inhibitors: rivaroxaban, apixaban, edoxaban, betrixaban. But dabigatran is a thrombin inhibitor or direct thrombin inhibitor, much less commonly used under these circumstances. I've discussed this with you last time. These come in different half-lives. They're very similar. Their renal excretion and renal disposal can vary. So you can actually pick and choose. If you've got renal impairment patients, you can have interacting with other drugs. You can choose between them. And it's very important that these are the different studies looking at DUACs in cancer-associated thrombosis. Some of these are completed, some of these are ongoing. So this is the first study which looks at edoxaban. The Hawkeye study looks at edoxaban, and as you can see, it showed that it compares very well with deltaparin, which is the low molecular weight heparin. Deltaparin is the original low molecular weight heparin which were used in the CLOT study. So this have shown the efficacy in terms of recurrence of thrombosis very similar. The safety have shown that there's a slight increase in bleeding in patients with DUACs or edoxaban in this case. And this increase in the risk of bleeding, if you look at my red highlighted number there, which is 5.6% as compared to 3.2% in the deltaparin group, but otherwise they're very similar. There was no clinically significant difference in between the numbers. This is the second study using rivaroxaban. It's called SELECT-D study. And this is comparing, again, deltaparin with rivaroxaban. It's extremely similar message to the edoxaban study, showing that the efficacy is equivalent in terms of recurrence, prevention of venous thromboembolism. On the trade-off, is unfortunately is a slight increase in the risk of bleeding. So they're sharing a very similar efficacy. And you look at the measure bleeding there, row 5.4% in the rivaroxaban arm as compared to 3% in the deltaparin arm. And otherwise, the efficacy is very similar. These are the other studies, which if you put these things together, if you look at the clot, catch, Hokusai, select D, they're all giving you very similar data, showing the efficacy is very similar between DUAX and low molecular weight heparin, but there is slight increased risk of those taking DUAX. Now, the increased risk is very much related to the site of cancer. So if you actually choose your patients well, so the risk of bleeding is much more common in people with gastrointestinal cancer. If you exclude those patients from your population, and this is exactly what the ADAM VTE trial did, using apixaban, but they've excluded patients with colorectal, with gastrointestinal tract cancers, and they had 0% of bleeding in 145 patients. This study has been completed and actually has managed to show very good efficacy and safety profile if you actually select your patients. And those with gastrointestinal cancer have been excluded. And that's what we do in our clinical practice nowadays. We wouldn't recommend DUAX in somebody who had stomach or upper intestinal cancer because of that risk. We've compared low molecular weight heparin with vitamin K antagonists. How does DUAX compare with low molecular weight heparin? So this is the new group as compared to the gold standard, which is low molecular weight heparin. And as you can see, the top half of the slide is related to efficacy. So that's recurrence of venous thromboembolism. And the bottom one is related to risk of bleeding. And as you can see, that DUAX seems to be favored in terms of, or equivalent when it comes to the risk of recurrence. But there's a slight increased risk of bleeding as compared to this when it comes to the safety. And therefore, this is where we end now. DUAX as effective in recurrence prevention, but in certain groups of patients, it may increase the risk of bleeding. To conclude in my talk, I think most of the studies, evidence-based consensus, recommend low molecular weight heparin for the initial and long-term treatment of cancer-associated thrombosis. And the recommendation is based on fairly solid background in terms of randomized studies, long-term safety data. DUAX are coming up as a serious contender for low molecular weight heparin as a modality for treatment. And if you select your patient, you will make their life a lot easier because these are tablets they can take in the comfort of their home. They're not injections, they're not painful. They don't have issues with things like heparin-induced thrombocytopenia, which is a complication can happen in these patients and can complicate their life. So I think you will see more and more patients having treatment for their cancer-associated thrombosis with DUAX in the future. And I'll leave you with some useful references there, and I'll be very happy to take some questions from any of you.
شكرا جزيلا دكتور. بارك الله فيك. It was a quite wonderful journey between these rigorous articles. Really I enjoyed it. شكرا جزيلا. كان فيه عندنا سؤال من الدكتورة منى. دكتورة منى يا ريت لو سمحتي تسألي السؤال لأن مش واضح لي أي سلايد اللي حضرتك ذكر عليها تعليق. تفضلي دكتورة. دكتورة منى. هي الدكتورة كاتبة في السؤال هي كتبت إنها to repeat slide على الديوريشن، بس ما فهمتش من سؤالها، فياريت الدكتورة لو مش قادرة تدوي وممكن تسألينا حتى سؤال ديريه كتابة، ولو في حد تاني معلش عنده سؤال ممكن يرفع إيده.
Please repeat, explain last slide. I mean duration. So that was, I think the duration of anticoagulation in cancer-associated thrombosis is very simple. Oops, sorry. Can you hear me?
دكتور هي كتبت توا الدكتورة
نعم.
قالت the duration of use of anticoagulation in case of BE and DVT.
Okay, so in cancer-associated thrombosis, 6 months is considered the minimum period for anticoagulation. If the patient at 6 months is cancer-free and they have no problems, no need for other anti-cancer therapy, and they are fully mobile, you can stop anticoagulation. If the patient cancer is still not acute or not still the patient undergoing treatment, you carry on anticoagulation as long as that's the case.
Okay, thanks. دكتور نبي نسأل حضرتك في المختبر as a clinical pathologist.
نعم.
ممكن هل تعطينا شوية على الاكسبيرينس بتاعك مع الحالات هذين؟
Okay, so the role of the the laboratory in these patients is there are several points. The first one is when the patient have recurrence of thrombosis, despite being anticoagulated, the laboratory input becomes very valuable because that's where you can help with monitoring of the anticoagulation. Okay, and what we do with these patients, we actually monitor their anti-TNA level. So the measuring the anti-TNA level is very valuable for these patients because you can, if you look at the recommended anti-TNA level for low-molecular weight heparin, it's between 0.7 to 1.1 normally. For these patients, we can actually go to up to 2.0 because what you're trying to do, the lab will help you to know, despite the fact that the patient anti-TNA level is within range, but they're still having a lot of thrombin generation. So you can measure that, okay? The second group of patients who are very important to look at is those who have chemotherapy or cancer-associated thrombocytopenia. In addition to the thrombosis, they have thrombocytopenia. So they present to you a very difficult situation where is this thrombocytopenia related to chemotherapy? Is it caused by cancer? Is it caused by heparin? So the heparin-induced thrombocytopenia is very important differential here because it can also cause recurrence of thrombosis and can drive the problem. You need to know if they have HET or not because the HET treatment is completely different from treating somebody with thrombosis who doesn't have HET. Because you cannot continue with low-molecular weight heparin. You have to use argatroban or fondaparonex, or you have to use a different agent. The third group of patients I mentioned earlier on, when you are doing the screening at the presentation, if their D dimers are very high, like over 3,000, and they presented with unprovoked venous thromboembolism, then you look for cancer because when the D dimer is very high, it can be indicative. There may be the D dimer caused by the thrombosis as well by the cancer itself. So these are the laboratory related activity in cancer-associated thrombosis where you want to be aware as how the lab can help managing these patients.
Thank you. دكتور حاجة تانية، هل مثلا الرول بتاع اللابوراتوري to know if it's DIC ولا microangiopathic anemia، لأن هن الاثنين ممكن يكونوا مع الكانسر. Isn't it?
Yeah, of course.
Does it play a role في الحالة هذه؟
So the laboratory looking at the blood film, we discussed last week some of the emergencies, and we touched on TTP and DIC. Is very important to help the clinical colleagues about which direction they need to go. Having said that, most of these patients may have the two conditions. You may have somebody with pulmonary embolism, and yet they have a DIC. So the laboratory can direct the management of, for example, anticoagulation in somebody who is DICing can be quite challenging and can be quite dangerous. But you may have to do it, and the laboratory can actually inform and guide the physicians and the clinicians in that direction.
شكرا جزيلا دكتور. الحاجة الثانية دكتور اللي لاحظتها من ملاحظتك من محاضرتك القيمة، إن يعني لو الواحد عنده فيميل بيشنت، لأن عادة يقولون الفيميل هي أن الVTE أكثر في الفيميل من الميلز، بينما الBE أكثر في الميلز. Isn't it?
I'm not sure there is a specific. I think females, obviously, there is increased incidence of venous thromboembolism in general because they use the contraceptive pill, they use HRT. The pregnancy is a very big risk factor for in general. I'm not talking about cancer here. I'm talking about venous thromboembolism in general. And if you look at the data, you will see the multimodal sort of curves in women. Men, they have more risk of recurrence of thrombosis. So nowadays, it's more likely that men will recur if they had first event of thrombosis. Some of you will know something called DASH score. We use the DASH score to identify what is the risk of recurrence of thrombosis. And the DASH score in women, if they have hormonal associated thrombosis, for example, they score less. And therefore, it means if they stop taking the oral contraceptive or the HRT, their risk of recurrence is less than if they were men. But I'm not aware of the DVT and a PE sort of as two completely sort of separate statistical significance.
اوكي شكرا. وفي الحاجه الثانيه دكتور، حتى التايب اوف تيومرز، مثلا لما يكون البنكرياس والستومك هم في التوب عاده، وبعدين الجينيكولوجيكال تيومرز.
So the adenocarcinoma. So all these you're describing, pancreas, stomach, ovarian, they all share in common that a lot of them are mucin excreting tumors. We mentioned earlier on about adhesion molecules as a pathogenesis element in the venous thromboembolism and the activation of the thrombin generation and initiation of the blood clot. And the reason for that is mucin escapes into the circulation and activates the coagulation cascade directly. So these adenocarcinoma, tumors, pancreas, stomach, ovarian, some of the colorectal, all can be a prelude for venous thromboembolism. Obviously, the data and the historical, if you look at Thrombosis sign, if you look at Virchow and all these early stages who reported on venous thromboembolism, there's more historical links with pancreas. But actually, it's relatively common in most of the adenocarcinoma type cancers.
جزيلا دكتور. في عندنا سؤال من الدكتور صبري. دكتور صبري يسأل إذا كان measurement of antithrombin 3 useful in CAT.
The antithrombin 3 can also only useful in people with acute lymphoblastic leukemia undergoing L-asparagine therapy. So L-asparginase can reduce your antithrombin level, and in patients who are undergoing ALL induction, taking L-asparginase, we would advise monitoring of their antithrombin levels, but not in the other general sense. Now, the other group of patients who you can monitor antithrombin 3 if they've got renal cancer with nephrotic syndrome, because with the nephrotic syndrome, there's a lot of excretion of the antithrombin as part of the proteinuria.
دكتور بارك الله فيك. إذا كان في حد عنده سؤال، الموضوع كان شيق جدا دكتور، شغلك كان باين، بارك الله فيك. فعلا الارتكلز كان very nice, you took it in a serious way and in very elaborative way. Really I enjoyed it. الدكاترة لو في أي حد عنده سؤال يا ريت تفضل. البين إن ما فيش حد عنده، فشكرا جزيلا يا دكتور، جزاك الله خيرا. فعلا محاضرة قيمة. معلش، في الدكتورة منى جرين قالت لك البنكرياتيك كانسر النون كوز اوف VTE، يعني هذا مجرد تعليق.
نعم
طبعا
نعم
هو نعم هو نون اوكي. فشكرا جزيلا دكتور. وان شاء الله نتلاقوا الشهر الجاي في ميزان حسناتك.
يلا بالتوفيق، نشوفكم على خير ان شاء الله.
مع السلامة.